All right, colleagues, welcome to The Explainer. Today, we're diving deep into septic arthritis. Now, this is a condition where the clock is always ticking. A rapid, precise clinical response isn't just ideal, it's absolutely critical for a good outcome.
So here's our game plan. We'll kick things off by defining septic arthritis, then get into the nitty-gritty of diagnostics and the usual microbial suspects. After that, we'll talk treatment, prevention, and team management. And to wrap it all up, we'll look at some of the nasty complications and run through a few clinical cases to put it all into practice.
All right, let's get started. First things first, what are we really talking about when we say septic arthritis? Okay, this is a really important distinction to make right out of the gate. You've got septic arthritis on one side and reactive arthritis on the other. They can look similar, but they're fundamentally different beasts. With septic arthritis, you've got a direct, hostile takeover. Bacteria are literally invading the joint space. Reactive arthritis, that's more like an echo. The infection is somewhere else in the body, and the joint is just having an immune freakout in response. No live bugs in the joint itself. Big difference. So how does this present clinically? Well, the signs are pretty much textbook, right? You're looking for a single joint, often a big one like the knee or the hip, that's screaming for help. It's going to be red, it's going to be warm to the touch, and the pain is often described as exquisite, which is a clinical way of saying it's absolutely excruciating. Movement is severely limited. And here's the kicker. Even though the problem is in the joint, the cause is usually hematogenous. The bacteria hitched a ride through the bloodstream from an infection somewhere else entirely. Okay, so you've got a strong clinical suspicion. Now what? Let's move on to the diagnostics. This is where we turn that suspicion into solid microbiological proof. Getting the diagnosis right really hinges on being meticulous with your lab work. Synovial fluid analysis, that's your bread and butter, the absolute gold standard. And if you're dealing with a prosthetic joint, getting those intraoperative tissue samples is non-negotiable. Now, if there's one rule you can't break, it's this. Get your samples before a single drop of antibiotics goes in. And don't just take one. Taking multiple samples is so important. It dramatically increases your chances of finding the bug and, just as crucially, helps you tell a true pathogen from some random contaminant. All right, so we've sent our samples off to the lab. What are we expecting to find? Let's take a look at the usual suspects in this microbial lineup. As you can see here, the microbial world we're dealing with is pretty diverse. Of course, you have the big one, Staphylococcus aureus. This guy is a major player across the board, from simple skin infections all the way to nasty prosthetic joint infections. Then you've got your beta hemolytic strep, which is the classic cause of erysipelas. But I want to point out one that's super important, especially for those prosthetic joints, Cutibacterium acnes. It's a tricky one. It grows slowly, so it can be missed, but it can absolutely be the culprit behind a stubborn, chronic infection. Okay, diagnosis is in. We know our enemy. So, how do we fight back? The therapeutic approach has got to be a 1-2 punch. Aggressive and highly targeted. Treating this, especially with a prosthesis involved, is really a two-pronged attack. You can't just do one or the other. Step 1 is surgery. That's non-negotiable. You got to get in there, clean out all the infected tissue. That's debridement. For prosthetics, you might use a strategy called DARE, which is debridement, antibiotics, and implant retention. Then, hot on its heels, comes step 2, a long, sustained course of the right antibiotics to wipe out whatever is left. So when we start antibiotics, how do we give them? Initially, it has to be parenteral, through an IV. Why? Because we need to get high concentrations of that drug to the joint, and we need to do it fast. And for a big class of drugs like the beta-lactams, the best way to do this is with a continuous infusion. This keeps the drug levels above the minimum needed to kill the bacteria for the longest possible time, really maximizing their effectiveness. You know, all this talk about cultures and chemistry brings a really terrible joke to mind. Why did the microbiologist and the pathologist break up? Because they just didn't have any chemistry, only culture. I know, don't quit my day job. All right, let's get back to the serious stuff. Antibiotic regimens. Okay, so this table gives you a nice snapshot of some common regimens for adults. You can see the difference, right? For something like a superficial ulcer with cellulitis, you might be looking at oral flucloxacillin.
But for something more severe, like chronic osteomyelitis, you're hitting it hard with an IV combo. Now, the really crucial point here, especially for those S. aureus prosthetic infections, is the addition of rifampin. You absolutely need it to bust through that protective biofilm the bacteria create. And just a quick note, while these are adult regimens, it's a different ballgame in kids. Dosing is all based on weight, and you start seeing different pathogens pop up, like Kingella kingai.
So we've dealt with the acute infection, but our job isn't done. How do we manage this long term? And even more importantly, how do we prevent it from happening in the first place? This is where the idea of team management really shines. You can't tackle this in a silo. It takes a multidisciplinary team, orthopedics, infectious diseases, microbiology, all working together. And a huge part of this is getting back to basics, meticulous hand hygiene, impeccable wound care. But it's also about the bigger picture. That means smart antibiotic stewardship, following national or even international guidelines to make sure we're using these precious resources wisely and fighting off resistance. And of course, following any local reporting requirements is key for public health tracking.
All right, to round this out, let's look at what happens when things go wrong, the serious complications. Then we'll put all our knowledge to the test with a few clinical cases. Let's be blunt. The consequences of messing this up are severe. If you have an S. aureus bacteremia that's not treated properly, you're looking at a high mortality rate, period. It can also lead to devastating downstream effects like osteomyelitis or even endocarditis. The infection can go metastatic, basically setting up shop in new locations. In adults, that's often the vertebrae. In children, it's the long bones. This is not something to take lightly. Okay, let's try a case. Picture this. A 45-year-old fisherman walks in. He's got this non-purulent cellulitis on his hand. Now, think about his job. What organism should be jumping to the top of your differential? And the answer is Erysipelothryx rhusiopathii. We call the condition erysipeloid. It's just the perfect example of why asking what do you do for a living can be one of the most important questions in your clinical history.
All right, case number 2. This is a common and really challenging one. You have a patient with a prosthetic knee, put in over 6 months ago. Now they're presenting with acute pain and a fever. It smells like a late acute infection. What are your first, most essential diagnostic moves?
You've got to hit it from 2 angles. Blood cultures and synovial fluid analysis are both absolutely critical. And if and when they go to surgery, remember what we talked about, multiple intraoperative cultures. It is the standard of care for a reason. That robust sampling is your best insurance policy against missing the pathogen or getting fooled by a contaminant.
Okay, last one, a real bread and butter clinical question. You're treating a superficial ulcer with some local cellulitis using flucloxacillin. What's the standard adult dose, frequency, and duration you're going to write on that script?
The standard answer here is 500 milligrams 4 times a day, and you're going to run that for 10 to 14 days. That regimen is designed to keep the drug levels consistently high enough to wipe out the usual suspects, your staph and strep.
And that brings us to our final thought, and it's a big one. We're living in an era of ever-increasing antimicrobial resistance. So the question for all of us is, how do our protocols for septic arthritis need to evolve to stay effective? This isn't a static field. The challenge is constant. We have to push for faster diagnostics, champion smarter stewardship, and constantly adapt our strategies to stay one step ahead of the bugs. It's a fight we can't afford to lose. Thanks for joining this explainer.